Okay, welcome everybody. Thanks so much for coming to this workshop on this rainy Friday afternoon in Ottawa after a lovely week talking about obesity. Today we're going to talk about clinical cases in obesity pharmacotherapy. My name's Sarah Chapelsky and I am a general internist from Edmonton. I have assembled a wonderful panel to help us sort through the cases that I'm going to present. But before I introduce this panel, I wanted to first take a look at how we got to where we are today. So let's start by taking a look at the history of obesity medications in Canada. Now, thinking about obesity medication use throughout the history of medicine, it really is a fascinating story, but I'm just going to focus on the recent history here. So our first stop is going to be in 2010. In this year, the weight loss medication sibutramine was withdrawn from the Canadian market. This was done voluntarily by the drug company on the basis of concerns about cardiovascular risk that came out of some of their trials. And this, of course, left a mark on many physicians who care for patients living with obesity, but also on their patients themselves. And I know that in my own practice, I see patients who have previously been on sibutramine. Some of these patients are eager to explore a new obesity medication because they remember having a great result with it. But for other patients, it brings up a lot of concern because they had to stop that medication, they regained weight, and they wonder about what's going to happen if I have to stop this great tool that I had once again. With sibutramine no longer available, this left only one medication for obesity management in Canada, and that was orlistat. And our next time point is going to be in 2015. And in 2015, published in our Canadian Medical Association journal, the Canadian Task Force on Preventative Healthcare actually made a recommendation against the routine use of obesity pharmacotherapy, specifically orlistat. And I think a number of obesity medicine physicians were really disappointed by this recommendation. And for those of you who heard Dr. Sue Peterson talk yesterday, she actually referred to it as something that was categorically unacceptable. So she did not agree with that interpretation of the evidence. And this was in a year where just a few months later, the weight loss medication liraglutide at a dose of 3 milligrams was approved by Health Canada for chronic weight management. Fast forward another few years, this is now spring of 2018, just about a year ago, the weight loss medication naltrexone-bupropion in an extended release formulation was also approved by Health Canada. So this left us with 3 medications now on the market. Now, thinking about having some new tools available in clinical practice and how you go about introducing that into clinical practice. So I'm going to tell you about my own process that I think was probably very similar for those of you who also prescribe medications. So the first thing I did was a lot of reading, right? I read the product monograph, reviewed the clinical trials. I also attended some CME events. And I also had the good fortune of having a pretty large group of physician colleagues who are also treating patients with obesity. So I talked to them. What are you going to do? Who are you going to prescribe this to? What side effects are you worried about? How are you going to monitor all these things? And of course, from there, we took it into clinical practice. Now, there's some real challenges when we're taking data from clinical trials and expert recommendations and now incorporating them into clinical practice. So often our patients don't quite look exactly like those patients that would have been enrolled in trials. For example, in all of our weight loss medication trials, patients must have a stable weight when they're entered into the trial. How many of our patients are actually still actively losing weight, actively gaining weight when they're first seeing us? And so, these early clinical experiences, I think, then really triggered an iterative process where you go back and re-examine what's in the literature, go to more CME events so you can ask questions. And what we're going to do here today, talk to our colleagues about what they're seeing and how they're managing these areas in particular that are a little bit gray. Now it's time for me to introduce my panel. I'm going to start with myself. I'm a general internist at the Edmonton Adult Bariatric Specialty Clinic. This is a provincially funded, hospital-based weight management clinic where we offer both medical and surgical options for obesity treatment. Next, right over to my right, I have Dr. David Harris. Dr. Harris is an endocrinologist here in Ottawa at the Leaf Medical Weight Management Clinic, which is a community-based, multidisciplinary medical weight management clinic. Dr. Harris is also the medical director of the bariatric surgery program over in Richmond, which is in the Lower Mainland of British Columbia. Dr. Isabelle Gagnon is a family physician from Whitehorse. She is at WeightWise Yukon, which is, again, a government-funded, community-based, multidisciplinary weight management clinic. She is all the way over there on the right. And in the middle, Dr. Tom Ransom is an endocrinologist as well at Dalhousie University in Halifax. He has a clinical focus on cardiometabolic risk factor reduction. He's also the medical director of their bariatric surgery program, and he has this very fascinating history of also being a dietitian by training. Now, that's my panel. I did want to get to know you guys a little bit. So how many of you are, in your role in looking after patients with obesity, able to prescribe medications? Of those with their hands up, how many of you are prescribing obesity medications right now? Most of you, that's great. How many of you are involved in the care of patients living with obesity but not actively prescribing medications? Super, thank you so much. Now, none of us have received any fees for preparing this talk or giving this presentation today. But as we think about introducing new tools into practice, I did want to talk to you about potential sources of bias, because I think this is a point in time where bias potentially plays more of a role than perhaps at any other time in clinical practice. So as we've alluded to, we all have financial interests. However, these are the most easy to identify and therefore manage. Weight bias is something that we've talked about a lot over the course of the week. And I think even for those of us who work day to day in the care of patients living with obesity, this is still something that exists and something that we have to manage. And I know for myself personally, I'm an internist. I place a high value on reduction of metabolic risk factors. And I often do have to take a step back when I'm thinking about treating a patient and weighing the risks and benefits about those ways that obesity impacts their life that don't have to do with metabolic risk factors. How does it affect their mobility? How does it affect their self-esteem and all those other things that are really, really important to overall patient quality of life? Again, our early clinical experiences, how does that influence how we now incorporate these new tools over time? So if the first patient we see has an above average response to a weight loss medication, are we going to be more likely to utilize that in the future? Probably. What if one of our early patients has a serious side effect? How is that going to influence our practice over time? And lastly, obesity is so common. We all have family and friends living with this condition. I'm sure, like myself, you guys also have lots of conversations with them. Some of those people may be on medications, and how have their experiences influenced our clinical practice? Okay, I wanted to do a little bit of a roadmap for today. Now, I know that most of you, or that many of you are already utilizing medications, but so that we don't leave anybody behind, I'm going to do a very brief overview of our weight loss medications, just a few slides. After that, we're going to dive right into cases. I'm going to present a case. I'm going to turn it over to our panel for discussion. I am going to leave some time for perhaps 1 or 2 questions after each case. I would ask that your questions at that point in time are really around items that we've brought up in the case. And overall, we're going to have a pretty relaxed afternoon. I'm going to leave a lot of time at the end for questions if you want to discuss issues that haven't been highlighted in the cases that we have chosen today. Okay, so first let's review the indications for obesity medications. It's the same for all of our obesity medications. It's to be used as an adjunct to lifestyle modification in adults that have a starting BMI of 30 or greater, or if they have a weight-related comorbidity, a BMI of 27 or greater. And in all the product monographs, there is this note that we need to reassess patients after they've been on the target dose of medications for 3 months. And if they haven't lost 5% of their initial body weight, the medication should be discontinued. Again, the medications that we have available, orlistat, trade name Xenical, liraglutide, trade name Saxenda, and naltrexone-bupropion, an extended-release formulation, which is a mouthful. We're going to call it NB today, and of course, the trade name is Contrave. Orlistat is a gastrointestinal lipase inhibitor, so it decreases a person's ability to break down and absorb fat. Now, if patients eat a high-fat diet, they typically have quite intolerable gastrointestinal side effects. So for patients that utilize this medication over the long term, really the way that it works for weight loss is by promoting compliance with a calorie-restricted, low-fat diet. Our newer medications work very differently. These are centrally acting medications, so they work through different mechanisms, but they both work centrally on our hunger and satiety centers, and they decrease food intake. Let's take a look at our weight loss outcomes. So we'll first look at 1 year placebo-subtracted weight loss. Average weight loss with orlistat, 2.6 kilograms, about twice as much weight loss seen with liraglutide and NB. And when we look at categorical weight loss, so how many of these patients are losing more than 5% or more than 10% of their initial body weight, you'll see that all of our medications result in a significant increase in how many patients reach these targets. We tend to see slightly fewer of those patients achieve these weight loss targets with orlistat, a little bit more patients achieving those targets with NB, and slightly more again with liraglutide. Now, I think looking at contraindications and cautions is really important because I find that this is where most of the tension arises in clinical practice about thinking about risk-benefit analysis and whether a patient should be offered an obesity medication. For orlistat, many of the contraindications and cautions are related to that decreased absorption of fat and fat-soluble vitamins. So it's not to be used in patients with chronic malabsorption or cholestasis. It results in an increased risk of kidney stones, and there is an idiopathic risk of hepatotoxicity with this medication. With liraglutide, contraindications, personal or family history of medullary thyroid carcinoma, or MEN2. And cautions are around an increased risk of gallstones, and also an increased risk of pancreatitis, which is most often related to gallstones, but also sometimes not. With NB, contraindications related to that naltrexone component have to do with the fact that it is an opiate receptor blocker. So it decreases the effectiveness of opiate medications, so not to be used in patients on that class of medications. The contraindications that are related to the bupropion component, history of seizure, uncontrolled hypertension, and some drug-drug interactions to be aware about. Now, all of our weight loss medications are also contraindicated in pregnancy and breastfeeding. With that, let's dive into the cases. So our first patient, are you guys ready? Yeah, I actually just put those introductory slides in to make you sweat a little bit, so. Our first patient, Julie, is 44. She's a regional retail manager. She has a history of weight cycling, so she's tried every commercial weight loss diet out there. She always loses weight and then always regains weight thereafter. Right now, she's at her lifetime highest weight with a BMI of 40.3. Because she's always on the road with work, she eats out frequently. She finds her job really stressful. There's lots of sales targets and so forth that she needs to meet. So often when she's out traveling, she'll end up binge drinking with her colleagues and sometimes also when she gets home. She tells you that she does have a lot of anxiety that's often affecting her sleep. She tells you that she's healthy. You have some screening lab work. That all looks normal. But you're flipping back through some lab results and see that a radiologist in the past has indicated that she has fatty liver infiltration. Julie has a friend who was also at your clinic, got prescribed a weight loss medication and is having a great result. Julie wants a medication, so she's coming to see you so that you can prescribe her a weight loss medication. All right, guys, you're up. I am going to start with Isabel. Tell me about your overall approach to this case. What are you thinking?
So a little bit of a background. I have the chance to work with a team that is readily available, and so I would use my team first. So I would agree with the patient that yes, she qualifies for medication, but that I would go to some steps before. And first one would be to ask her to do a food journal for a week or two and see our dietitian to review the food journal. When they come to our office, they fill about this thick of questionnaires and questions, which would address the anxiety and the sleep and the drinking. So I would review these with her, and I would probably look at addressing the anxiety with a medication if it wasn't done before, and follow up with her in a short period so she doesn't feel that she's not going to get her medication. So that's what I would do for now.
Do any of my other panelists have any other comments on this one?
So in the initial discussion, we were talking about this. She's been struggling with this for years, and we're thinking, the next 4 decades, so that we're not going to try and fix it all on the first visit. And so there'll be education about the medications. I have a, almost like a spiel where I, patient-friendly descriptor of the 3 medications. I usually write them down and ask them to Google it. I'm a big fan of people actually Googling these things. But likewise, I say, there's a number of things that need to be addressed, from her anxiety, her binge drinking, and through the dietitian, just, approaches to eating healthy while on the road. She probably says, oh, I've heard it all. It depends on her prior interactions with other, dietitians in the past. She's history of cycling. But, just remind her, reassure her that we're going to pick a medication, likely pick a medication. I can't, most assuredly. I'd also give information about potential, has fatty liver and stuff like that. She'd be a candidate for bariatric surgery. And where we are, if your name goes on the list, you get a letter that says 8 to 10 years. So I said, I don't know where you're going to be 3, 5, 8 years from now, so we'd probably put your name on your list just in case. But we'd have that discussion and try and see back relatively soon and pick up the conversation from there.
Okay, thanks so much. So let's do follow-up on this case. She's started on escitalopram and her anxiety is diminished. Okay, I see Isabel smiling, because I do actually want to know what medication would you have prescribed in this circumstance? You would have gone with this one.
Yeah, I'm giving you.
Oh, good. Okay. All right.
Maybe sometimes I like to use duloxetine.
Yes.
Because it can trigger weight loss.
Yes.
But that's weight neutral.
Okay.
I just avoid the weight gain ones.
Mm-hmm. Can you specifically say which medications you might be particularly worried about?
Well, I went to a talk where she said that some of the weight gain SSRIs sometimes trigger weight loss on some patients. So now I'm not sure this is appropriate anymore. But yeah.
Okay. Her alcohol intake is moderated, right? So she's probably met your dietitian already. She's done some thinking about the calories in alcohol. So she is drinking less, although still occasionally will enjoy 3 or 4 servings of alcohol when she's out with her colleagues from work. She's still eating out a lot because her job is just so challenging. But she tells you that she's paying a little bit more attention and she's trying to choose lower calorie options when eating out. She has insurance coverage for medications. So is this something that you guys are typically asking people or talking to them about on your first meeting? Yeah, all around, right? So this is a real barrier for our patients. So tell me now, I think, as you guys had said, you take a look at things, optimize the patient as best you can, try to remove any barriers to weight loss or start managing them. Now we have a patient who's going to start a weight loss medication. I wanted to talk to you guys a little bit about how you decide on which medication to start this patient on. So I see Dr. Harris nodding. So tell me first about patient characteristics that you think are really important. So from your side of the table, which factors might make you recommend one medication over another?
So in this case, my overwhelming feeling is that I would be leaning more towards offering liraglutide to this patient first for a number of reasons. Naltrexone-bupropion, even in the patient who addresses anxiety, is on a mood stabilizing medication, does all these lifestyle things that we just talked about, I'm still running into probably, in my practice, 1 in 40 to 1 in 50. If a person has general anxiety disorder, that they have overstimulation with bupropion when you initiate it, even on 1 tablet a day, and that 1 in 30 to 1 in 50 patients has come back to me and said, I wasn't even able to sleep. So you really have to have a good feeling about the person's background around the anxiety, and that's maybe a strong reason you don't offer medications to this person the first time you meet them. You have to get to know them first. And get a clinical feel for where they're at with that. This person has a big story of quick fixes. Lots of quick fixes, no planning, less organization, eating out. I always call it in my clinic, a quick fix is a mistake for something you already did. Just the same way that sliding scales in diabetic care is the same. It's a correction for a mistake that happened with dysglycemia already. And that's what a quick fix is too, that the person wasn't able to organize and approach that. Oftentimes when you go for a quick fix, you might be tending to go towards a higher caloric reward tendency. So that could be an argument for Contrave in this case, due to like cravings and, naltrexone-bupropion for cravings and reward tendencies. But ultimately, I think that if this person has a tendency to go for quick fixes, snacking, maybe junk food, etc., that maybe trying to dampen their overall background need and want for fuel in their diet might be a better approach with that drug first. So, and then, so that would be my consideration. I'd probably offer liraglutide in this case first.
I'm going to direct this question to Dr. Ransom. So now maybe we're not considering this patient, but really a patient who is well optimized, no medical comorbidities, and you can't find a reason from your side of the table to recommend one medication over another. How do you counsel patients around that? How do you help, or how do you decide with them which medication to start with?
Okay, so she's come back and done a little bit of reading, and she may have a preference. And so again, we go through, and I have unless someone wants to hear my 90-second spiel, but we would go through, from orlistat, mechanism of action, side effects, like really spend some time going through each one. Injections, nausea, rationale of slow titration for NB as well. We work through them. If she says, well, I don't want an injection and I want the pills and I've come up and I want this, well, I'm going to talk to her, a little bit about the alcohol, increased nausea. This, that's going to be an issue. But I also have a discussion. Again, this is longer term, and so we talk. I bring in the 3-month stop rule. We're going to try it for 3 months. And my line is, we're better at checking and reacting than we are predicting. So even if we choose one and we think it's going to be the one that's appropriate, or we think is appropriate, it might not work, or they might not be able to tolerate it. And so we'll have that discussions, and if there's no effect, at 3 months, whether it's we save 5% or they're perceived, unless there's extenuating circumstances. But if they perceive it's working at 3 months, then we would renew the prescription. And so I'll draw it out, but I really try to get the patient to try and make the choice, because I do believe that patient-directed intervention, they're more likely to be adherent. I don't have data for that in terms of weight loss medications, but there is data in other medical realms that if the patient makes the choice, they're more likely to adhere.
Okay, great, thank you so much. So that is the end of this case. We're not going to take it to its resolution. I do want to know if anybody in the audience has any questions around patient characteristics or other factors that help you decide on a first medication. We'll take one question here.
If she has an issue with binge drinking, I would question binge eating. Yes. Because that would open the door to other possibilities in terms of using finance or addressing local psychological issues before deciding to prescribe.
Yes. Yeah, that's a great comment. So the comment was, if this patient is binge drinking, what other behaviors might she have, coping strategies might she have? Is binge eating a problem? Do some screening around that, and maybe we would consider an alternate medication addressing her binge eating, as well as other supportive interventions to help with that binge eating before tackling weight management. That's a great comment, thank you. Please, Dr. Harris, add to that.
I'll add to that too. My only problem with that point is the following. You're making a distinction between binge drinking and binge eating disorder. Now, when you look at the evidence behind binge eating disorders and use of Vyvanse and Concerta, for example, the pediatrician psychiatrists are the ones who are the most published in this area, and they look at moderate to higher degrees of binging tendencies, which overall means that you're binging every other day or daily or multiple times a day. Now, the classic binge drinker will be a weekend warrior. They'll be your Friday or Saturday night person in a social event. So to distinguish those two categories and say one is a gateway to another is a hard inference to draw. It's very hard to draw. That's my only concern about that. It's a slippery slope. Of course, if you're binging on alcohol daily, you're an alcoholic. You are not a binge drinker. You are a daily alcoholic. So it's tough to draw those parallels, but I totally respect your point. But I worry about the slippery slope about differentiating those two lifestyle characteristics. That's my only point.
Yeah, thank you. And I know that within all of our clinics, we all do very dedicated screening for binge eating disorder. So we didn't include it in this case, but our patients all will be screened for that. Yeah, thank you. Okay, let's move on to the next one. This is Lynn. She is 50. She owns a consulting firm. She has already lost 10% of her initial body weight utilizing liraglutide at a dose of 3 milligrams, and she is also on bupropion XL at a dose of 150 milligrams daily. With that 10% weight loss, she now is maintaining a BMI of 41.6. She has hypertension, GERD, osteoarthritis, and migraines. She's now presenting to one of our surgical centers because, while she has had a great weight loss, she thinks that there would be benefit with continued weight loss from where she is, so she's planning to have bariatric surgery. So she's now coming into one of our bariatric surgery centers, but she tells you that she really wants to lose as much weight as possible in advance of bariatric surgery. She thinks that that will reduce her perioperative risk, and also she is just interested in living as well as she can right now. And at our surgical center, the wait is going to be at least 12 months from this time when you are first seeing her in clinic. I will maybe have Dr. Harris start off on this one. What are your thoughts around this case?
So, I mean, first of all, you have to qualify Lynn's hard work already. It takes a lot of hard work to get 10% absolute weight reduction, so you congratulate her the first thing when you meet her. I think the immediate topic that comes to my mind in this case is balancing the patient's expectations for weight reduction using bariatric surgery versus maybe reality. This person has already had 10% absolute weight reduction. Now they're accessing a tool that is reported perhaps to give 25 to 40% range of further absolute weight reduction. And in this case, because she's already done superb multifactorial lifestyle work, that expectation that she's going to lose another additional 25 to 40% on top of that needs to be quantified for this patient. And because she's already started her journey well in advance of this surgery, if she has an expectation to lose the average maximum weight, you might have to put it in perspective for her and say, I just want to tell you that this tool might be tapered down to maybe only 25% weight reduction in this case. So that would be an important discussion to have with her about, she's already on 2 tools, adding a 3rd tool on basically to her care.
I think that's a really great point about adjusting weight loss expectations after bariatric surgery in patients who have done really well on medication. Did you see my Pechacucha this morning? I think I talked about that. Yeah, thanks, cool. Now, this patient is a really well-educated patient. So again, she comes back, she tells you that absolutely she understands that she may not lose as much weight as everybody else after bariatric surgery, but she still wants to maximize her weight loss. She thinks that her osteoarthritis is going to get better, and overall her life is going to get better with more weight loss. But she also tells you that 12 months is a long time to wait. She's heard there's a new medication out to help with weight loss. What do you guys think about adding that in this circumstance?
If we remove the bupropion, yes, we could do
Yeah.
this. We switch the bupropion for control.
Yeah, so-
we can definitely do this.
Yeah.
But before
Go ahead.
I'm a partisan of reassessing everything,
Yeah.
lifestyle, binge eating, the review by dietitian, and then if we find as a team that lifestyle has not much to change, then for sure we
Right.
could add the Contrave and remove the bupropion.
Got it.
Sorry, the naltrexone-bupropion.
Right, so you're saying even though she's had a great weight loss, you're
We
meeting
can
her for the
push it.
first time. This is an opportunity to reevaluate things, see whether there's barriers and any tweaks. If no, then consider a medication. Tom, would you have a concern about introducing NB in this scenario?
I'm comfortable combining the 2 medications, quite comfortable with that. There is always a cost issue, So depending on coverage or finances, and there are plans will cover one medication but not two. You start playing with things. Had she had diabetes, you might be able to switch to the Lira 3.0 down to 1.8, or switch it to semaglutide once weekly, which would allow you to add in the naltrexone-bupropion. And these are sort of the games you play, but those are something you might consider. I would remind her that if her BMI does drop under 40, she would still, if she didn't have diabetes, she would still be a candidate for bariatric surgery. It's an important, just something to remember, that if it's people's maximum weight, some people may have seen, had issues where their surgery wouldn't be covered because they no longer met the criteria, but it's from their maximum weight down, and we've successfully overcome that. That's no longer an issue, but you might have to remind the payer, depending where you are in that.
Thanks. Actually, I do want to ask you guys, for your patients who are now on 2 obesity medications, what have you found with coverage for a second medication for weight loss? Have you guys run into any trouble with that? What are you guys seeing?
Yes.
Yeah, you have. So out in Nova Scotia,
there's
yes.
different plans. Some plans will be, you get $1,000 a year towards weight loss medications, spend it how you care. Others it would just be one medication, and you're sort of justifying it. And there's the odd, and I would say odd because it's not common that a plan will cover 2. Hence, if they have diabetes or even metabolic, the impaired fasting glucose or something, you can tweak things and go down to 1.8, which will be covered, or another GLP-1 agonist, and you then use the NB. So those are sort of little games you play.
Yeah, I'll have to say I have been actually pleasantly surprised. Speaking to our U.S. colleagues, for most of their insurers, it sounds like one weight loss medication may be covered, but a second rarely is. With my patients in Alberta, what I've seen is either weight loss medications are covered or they're not. And when I try to add a second one, it's actually not a problem. I know that they'll get it. I'll say that the one plan I have not tried is our Alberta Blue Cross, our teachers. I'm not sure how that is playing out. Okay, our Dr. Sharma, yes?
Just the question, would anybody consider simply adding Mavia to this patient? Has anybody done that, or?
Sorry, simply adding
Mavia? Just the naltrexone?
the naltrexone. Dave,
We discussed
Dr.
that.
Harris?
I can talk to that, yeah. One of my colleagues at Leaf, we talk about this every Friday. Because there's a lot of people that don't have plans and they just want to go on an instant release, I guess you could say. Now, the problem with naltrexone instant release is a 50 milligram tablet is the lowest compounded in Canada. So you have to break that into quarters. And you're only allowed to, of course, take up to 3 quarters a day to get that 37.5, which roughly matches it. So my experience, which is like an N of 5 here, is that you don't get as big a bang for the medication efficacy as you would expect. So if you said, let's say with lifestyle intervention, bupropion, naltrexone will give you between 8 to 12 absolute body weight reduction. If you're using the original parent drugs, that you're going to taper that by anywhere from 2 to 4%. And so while it still works and it's better than nothing at all, the expectation is not as high. So yeah, a lot of our colleagues in Ottawa are doing it in certain cases, and it's working fairly well, but it's not as good as, of course, the branded drug. And I just had one other comment about this case too. Mm-hmm. An article that went around our clinic in the last 4 months was a retrospective review of people on liraglutide that had phentermine added to it in the United States. And Their summary from that trial was if someone had achieved 10 to 12% absolute body weight reduction on liraglutide, that adding phentermine onto it, we're talking about old school phentermine. We're talking about 15 milligrams starting dose and marching up to 30 to 45 a day, which is high side effects, but that there wasn't much more added benefit. That when someone got around that 12% mark, if you started to double up and keep interrogating the POMC, for example, that there wasn't much more benefit in doing that. So some of the naysayers in this case would also say there isn't a lot more benefit in trying to interrogate another part of the hunger center in this case, because you're already hovering around that 12% threshold right now. So that would be my only other comment about this case too. Yeah.
Please, Dr. Sharma.
Would you at all take into consideration how much this patient is eating? So if this patient was maintaining this weight but is only eating, let's say, 1,200 calories, and the whole point of adding a second medication is one more weight that she's going to have to eat even less, and now you're starting to drop her intake below 1,200 because you're going to run into nutritional issues. Is that a concern?
I think that's a really excellent question. Dr. Gagnon?
This is why I was referring to the dietitian prior to
Yeah.
the change, for sure, yeah.
I actually want, well, Dr. Ransom, do you
So, by this time, I would have a fairly good idea of what their caloric intake is already. And the way it goes for our patients post-bariatric surgery, they're all essentially going to be on a multivitamin for the rest of their life. And I drill that home even, 10 years before their surgery. You're going to be on this for life. But as we cut down, I really emphasize the importance of a multivitamin. So everybody leaves the clinic on one regardless when they're sort of in that 1,500 calorie range. And if their diet's quite poor, even 1,700 multivitamin. The evidence isn't super strong, but I also add vitamin D as well. There's some evidence, and some people suggest that actually helps, sort of augments, if you will. And the protein, and although I'm a dietitian, I work with the team. They're exceedingly well versed and better at motivational interviewing and behavior modification than I am. So work with a dietitian. But it's a very important point when these people get this low. So they leave the clinic on a multivitamin.
So to summarize, what Tom is saying is in these patients have to have low caloric intake in order to lose weight. And I always review with patients, if you're not eating few calories, it has to be high quality, and you may need to supplement with the multivitamin. Now, I do want to get back to your question, Dr. Sharma, which is, if this patient's already reporting a low caloric intake, would you try a medication? And what I was actually hoping Dr. Ransom would say is let's check and see what happens in 3 to 6 months and whether they've had a weight loss result. And, I think the same question sort of comes up. We have patients that tell us that they're not hungry. How would a weight loss medication work? We know that patients, even those that are really meticulous, are actually pretty bad at being really accurate about their caloric intake. So for me, the question is more around, does this patient see a benefit in losing more weight? Accepts a medication, and if she does, I would try it and see what happened and assess later on whether it's been efficacious or not. Okay, so this is a real life, go ahead. We will take one question.
There's another question that's like on that
Great.
note. Also, are the medications she's taking for her hypertension and migraines, they could be weight positive medication, and maybe we could look at changing those. Maybe,
That,
I mean, if she's on Advil, considering preparing for migraine.
yes.
So, I mean,
That's a great point. So another point around optimizing other factors that may be barriers to weight loss, and in particular, looking at the other medications that she's on. Are they contributing to her weight gain over time, and can they be switched out for something else? Okay, so in this patient, I did, as Isabel mentioned, transitioned her from her bupropion XL to naltrexone. She's now on liraglutide at 3 milligrams and NB at 2 tabs twice daily. I'm seeing her in follow-up at 3 months. She was having some nausea and constipation. I talked to her about how to manage her constipation and advised her that probably her nausea would still get better. Let's give it some more time. But then I also saw her 6 months later and she's still struggling with nausea. Tell me, I want to talk to you guys. So managing side effects of these medications is something that we have to do. So in this particular scenario, what would be your tips or approaches to managing, let's talk first about her nausea.
Decrease the liraglutide to 2.4.
Yeah, so, okay, yeah, agreed.
Try that.
So, yeah, so try submaximal dosing. I think of either compound. Would you have a preference of one over the other, decreasing it? I would try either. I would give the patients a lot of leeway in experimenting with it herself.
I mean, if you want to play the statistics games in the studies, NB has a much higher reported side effect of nausea and constipation, roughly at about a third of patients in the first 1 to 3 months of use. So my gut answer is reduce that 1 to 3 pills first. But I agree, liraglutide can do it too. So I would start with NB personally, but you could even be ultra conservative and reduce both. This person has done very well on dual therapies, so there's nothing wrong to say reduce both right now as well.
Are you guys ever utilizing anti-nausea medications either when starting the medication or over the long term to help mitigate these side effects?
No.
Nobody wants to answer. Oh dear.
I mean, PRN, Gravol.
Gravol?
Yeah,
Yeah.
I can't say that I've used any stronger anti-nauseants than that.
Okay.
In my practice, mostly PRN, Gravol.
Okay. For most of our patients, so again, I do have patients with ongoing nausea. This was one of them. But for me, by and far, the most common side effect that people come to me complaining about is constipation. How are you guys counseling around that? Dr. Gagnon?
Water, fibers.
What's your daily fluid intake is the first question that rolls off my tongue every
It's
time.
the diet.
Diet.
Initially.
Okay. It's not enough. What are you doing now?
Well, decreasing the medication as we suggested for the nausea, did it help her constipation as well?
Sorry, did.
By decreasing the medication, did it
Got
help?
it. So you'll do a dose reduction as well. That's another great strategy. Yeah. Anybody doing Orlistat?
You want a lot of pills.
Orlis, usually that would be the second. I have to tell you, I don't have anyone on triple therapy, but I do have people who are sort of using, or I wouldn't say Orlistat PRN, but I think, was it Sue Patterson mentioned maybe using 1 tablet of Orlistat, not a full dose, to help.
Yeah.
And that's perfectly reasonable. I just don't have anyone on triple therapy. I don't know if anyone here does, but I don't. But I've, and again, in explaining it, this is one of the reasons why there are people out there, when you give the options, pick Orlistat.
Right.
When it comes to choosing, someone says, "Yeah, that sounds perfect," and it's a good match.
Great. So this case, with switching her bupropion to naltrexone, this patient actually had an additional 10% weight loss. New BMI 37.5. We already talked, so she's reporting a fairly low calorie consumption, and we already sort of addressed how we would manage that. With that, we'll move on to the next case. Marcel is 48. He's an international businessman. Right now, his BMI is 38, and he's actually well off his lifetime highest weight. He's down by 25%. However, he has a very long history of weight management, has tried many, many things in the past. So starting in his 20s and early 30s, he has both tried and now come off metformin, sibutramine, Orlistat. He had minimal efficacy with these medications. So ultimately, when he was at his lifetime highest weight, which was a BMI of 52, he had a sleeve gastrectomy, and he went to Lebanon for that procedure. He did really well after his sleeve gastrectomy and had a nadir BMI of 39.5, but then started regaining weight. So what he did is go back to Lebanon, and he was revised to a single anastomosis gastric bypass. Again, he had a really great weight loss outcome. He got down to a low BMI of 35.5. But subsequently, again, that weight came back up, and this time he joined a comprehensive weight management clinic to help him manage this. He participated in an intensive behavioral intervention, was using a meal replacement, and now also started on liraglutide, and he had an excellent result. He's actually at his lifetime lowest weight with a BMI of 34. But of course, you're not seeing him at this point. You're seeing him a year later. And this patient is now regaining weight. He's still on liraglutide, but gaining, and his BMI is now 38. So my question to you around this particular case, this is really an illustration of obesity as a chronic disease, the requirement for lifelong management. He's on liraglutide and gaining weight. What are you guys gonna do around that? I actually am going to ask Isabel, you talk first about your overall assessment, please. What are you thinking?
Well, I would reassess from the start with the whole package of my questionnaires, because something could have been missed, especially binge eating disorder in this case. I would look into repeating lab work, everything. Make sure that all the comorbidities are under control, blood sugar, and I think we would find something.
You would find, so Elizabeth, Dr. Gagnon's going to go there. Tell me what you guys would do with the liraglutide. He's gaining weight. This medication isn't working. Dr. Harris?
So I definitely think he can consider switching to an alternate therapy. That's definitely one option. In this case, this guy is either on the wagon or off the wagon. He's on and off. He demonstrates a lot of use of tools, but maybe not supporting them always with a program or lifestyle. And comprehensive review and accountability for follow-up. He's a businessman coming and going out of the country. And my big concern about this fellow is if we give him another tool, that he's just going to use it for a while, but he's not going to support the tool. And so this is almost one of these cases where if he sees me, it's almost more talking about the foundation of what his life is and diet and exercise, lifestyle, etc. The comprehensive review that Isabel just mentioned. And trying to build on those things and practicing routine of lifestyle with him. Of course, changing the mechanism may be worthwhile. The other issue is he's on the go all the time. He's eating out. He's eating while he's traveling. He's lacking organization and planning. And for some folks, when they're on and off, sometimes he may look at continuing partial meal replacement long term as well. In this case, it seems like a year later he's off of it. He's sort of disengaged off that part of the therapy and only coming back on liraglutide. And so if he continues to demonstrate those patterns of eating out a lot, delivery, fast food, cafes, coffee shops, then he may do better with a low caloric meal replacement as well long term.
I see Dr. Ransom frowning.
I would just echo what they both said. We have to start from scratch. He's someone who's had his surgeries done elsewhere, probably not, I would anticipate not getting follow-up where he had his surgery. Maybe he's going back, but it's unlikely. See someone, he's looking for a fix. He sort of goes outside the system. I can go here, get it done. I can go there, get that done. And, hoping for a fix. So he's someone, hopefully where you are, you have access to a psychologist. I think that he really needs a comprehensive overview. He's only 48, so I just say, listen, you've got another 3 decades, 4 decades. We can't keep this up, so we've got to come up with a plan. I don't think this is really a pharmacologic issue. Yes, we could try and switch and see what happens, but I don't know if it's so much that if we took the liraglutide, would he just bounce up further if we took that away? Or in addition, whether it's liraglutide's not working, or thank God it's there, her would be in a worse state.
Right. So to summarize what you're thinking, liraglutide previously worked really well for him. Unless the patient is having a concern, a side effect, really wants to try stopping it, you'd probably leave it on there. Your concern is that he's going to have quicker weight gain, perhaps, if we discontinue it. I do want to challenge you guys a little bit because you've sort of brought this up. So in patients who are having a real struggle to adopt some healthier lifestyle habits, even though they've participated in comprehensive weight management programs in the past, should we not be giving these people medications? It says in our product monograph, we always need to use our medications as an adjunct to reduced calorie diet, increased physical activity. Are there bare minimums that patients need to meet before we're going to hand out that prescription? What's appropriate here?
Did you want to comment?
Go ahead.
Oh,
I don't think there'd be any utility to talking to this gentleman that perhaps the BMI 34 was below his best weight, that his best weight may be higher, that despite all these different interventions, that his weight is coming up, and perhaps it's just finding his best weight, given his lifestyle and everything that's going on. Regardless of, there are perhaps some things he can't change, he's doing his best, he has done the comprehensive program. That was the first point. The second point,
I just want to summarize what you said because I think it's really important. I want everybody to hear it. I think we always look at weight regain as being pathological, something that we should really try to avoid. And what Dr. Crotty brought up is that perhaps this patient actually undershot his best weight. Okay, so in this case, he's just experimenting. He's just finding what his best weight was, and that's really, really what he's done. So I think that that is a really great idea to explore. I think that you're right. We should spend time asking him about how restrictive was he with his diet at his weight nadir, how much was he having to exercise, how was complying with this lifestyle intervention affecting his overall enjoyment with life, his relationships, and so forth. I think that's a really excellent point. Thank you. You have another point?
I just wanted to mention as well, I'm a family doctor, and obviously for a lot of the medical conditions we see, blood pressure, diabetes, we're supposed to be taking, the product monograph says a comprehensive approach and then medication. We should be doing the same for blood pressure, for diabetes, or mental health issues. We seem quite quick to go to escitalopram for the lady with anxiety who with exercise, CBT, reducing her drinking may have improved her anxiety. We thought nothing of putting on an SSRI, and yet we're kind of holding back on some of the pharmacotherapy. So I think sometimes, does that speak to some of our own inherent weight bias? I agree. Absolutely, we should be doing a comprehensive approach, but we should be doing that across the board for everything.
Yes.
We often see somebody with high blood pressure, so if that lady came in with an A1C of 10.7, would you talk to her about kind of, diet and lifestyle?
Diet
You probably
before.
would, but you'd probably start on something for her sugars perhaps as well.
Yeah, that's another great point that I'm going to repeat. So Dr. Crotty, again, is pointing out that for most other chronic health conditions, we prescribe a medication, and then some of those lifestyle recommendations are an afterthought or something that we package together. Whereas often with obesity, we think about lifestyle first, optimize, and then think about a medication. All right, anything else that you guys wanted to mention on this one?
Well, I agree on when their weight is too low, they'll come to you and they'll tell you, I feel tired all the time. Friends and family are telling me I look sick. So definitely, it's not always positive to be, even if 34 looks still high, it's too low for him.
Yes, yeah, thanks. Thanks, great discussion. Okay, next one. Hey, this is a new one for the panel, guys. I slipped this one in last night. So Lauren is 31. She is a full-time mom. She has a couple preschoolers. She has struggled with her weight for a long time. Her weight gain started as a teenager. I'm going to just tell you, she has had diabetes that was diagnosed 5 years ago. So she's actually participated in a regional diabetes program, done some behavioral intervention with that, and as well was started on metformin and empagliflozin. And with that, she's lost 5% off her initial body weight in the last 18 months, and she now has a BMI of 38. Her diabetes is really well controlled now. She has a hemoglobin A1C of 6.7%. She comes to your weight management clinic. You guys do what you do, right? You do all the screening, identify barriers, manage all that. And of course, you pick liraglutide for her because she does have diabetes. Now, she is really ready to participate in this program. She gets some extra support at home. She's really ready to take care of herself. And over the ensuing 12 months, she has a 15% weight loss. Her BMI is now 32.2. And in addition to having a really great weight loss outcome, her diabetes control is now really excellent. So she has a hemoglobin A1C that's now 5.6%. She's no longer checking her blood sugars at home. She's still on metformin, empagliflozin, and liraglutide. She wonders if she still needs diabetes medications. She places a high value on discontinuing these medications. Being on so many medications makes her feel like a sick person and she wants to quit. What do you guys do in this scenario? I'm gonna lean on the endocrinologist for this one.
So, of course, commend her on her efforts. I mean, it goes without saying. She's really done well. But there's reminding patients if they're on antihypertensives and they say, "Oh, my blood pressure came down. I don't need my medication anymore." You take it away, it comes back. And so, in terms of glycemic control, say, well, can we let it drift up? And then say, you're 31. We're going for another. I'm always talking about, you've got another 5+ decades to go. You don't want any dysglycemia over that long, the long term. Diabetes is a progressive disease. Reminder of that, and under excellent control. And if she's tolerating it, I would be advocating and let her know my bias is to stay on these medications. And I guess that's where I would start. I would start there. I don't know if you want to add anything.
I mean, I would offer to stop her metformin.
Would you?
I would. And see what happens.
Tell me.
And see what happens.
And what are you looking for?
Well, the strategy is weight neutral or weight reduction provoking agents and the maintenance of them at all costs. Metformin, this is before my time. When metformin first came to market, I'm told that actually one of the pieces of the marketing was that it might cause weight reduction in people. But from my experience, only probably 1 in 25 people that are started on metformin de novo lose any degree of weight. And that might be ethnic based, that might be family history based, et cetera. So it doesn't really help the average person living with diabetes reduce their weight. Of course, empagliflozin and liraglutide have weight reduction as expected mechanisms, side effects, I suppose. So I'd always be trying to promote those two medications first above the metformin because I'm a weight loss specialist as well. Now, the naysayer could argue, well, there's much more strong evidence for metformin in this population long term based on the literature, but I still think that it's a partnership with your patient, and there's nothing that I appreciate more now that I'm getting close to a decade as an endocrinologist and understanding how many medications we pile on people. And when they're doing it every day, even just reduction of one pill will actually be a big success for her. And so that actually may even motivate her to keep working just as hard on her lifestyle long term. So I think that that's sort of recognizing that she's come a long way, and in a sense, you're rewarding her by reducing the total daily dose of medications a day. So that's what I would do in a liberal sense, but I agree with Tom that from a metabolic sense, the evidence would say leave things alone. But yeah, we're treating the patient too.
Did you want to take a stab at this one, Dr.
Yeah.
Danielle?
I'm not an endocrinologist,
We know.
but I honestly, by experience, if I would do this, but before I would make sure of the glycemic index of her diet, because patients with a really high glycemic index in their diet will come back in 3 months and she will have gained 15 pounds and will be really upset after I stopped the metformin that I gave the okay. So and I would keep the metformin and keep and stop the empagliflozin on my. If it was me, that's what I would have done. Yeah.
Okay.
Yeah.
Dr. Ransom?
So, so to review, any side effects whatsoever from GI to
Yes.
nocturia, polyuria, might say, well, maybe we can, might guide, say, well, we could, or reduce the medication. I will remind us that, it's not that you're sicker that more drugs have been added on, it's that we're trying to prevent you from being unwell. We're now starting to get more and more combination medications, so we could reduce pill burden.
Yes.
That's a possibility. But metformin, it's not uncommon. I mentioned to my patients that metformin's my favorite drug. I was at its 60th birthday party 2 years ago at EASD. And it's been around for a long time for a reason, and it has implications in cancer prevention, all sorts of things. I don't know if it's helping keeping her periods regular. I don't know what, but it's my favorite drug, and there's, but if she really wants to come off of a medication, I'm again always say, well, let's try it, and we can check and react. And if a few months of her A1C wouldn't go sky high, but a few months of increased glycemia there won't be any ill sequelae to her eyes or kidneys or feet or anything, but we can, it can certainly be tried.
And I'd say a third point is to appreciate the relative contribution of efficacy of each of those three agents. How much of each of these agents is effective in reducing her A1C? And that could be an argument strongly for leaving metformin alone. So I've done this. You stop metformin, or, for example, a sulfonylurea, classic. Let's replace the metformin with the sulfonylurea. You stop the sulfonylurea in this case, and they come in 3 to 6 months later, and their A1C is 7.3%. And so what do you do at that point? You add therapy back. And so you also have to appreciate that, of course, the higher you start, the more you'll fall with A1C regulation control, and metformin would be the biggest contributor there. So that would be an argument for leaving it alone, and also leaving empagliflozin alone and taking away liraglutide, because of the impact it has on the
From an
efficacy.
A1C perspective.
From an A1C perspective, yeah.
Interesting. Okay. Okay, thanks very much. Any questions or comments on this case? I'm going to go here.
I'm a pharmacist. So you can tell the patient why patients don't give the prescription filled. Because you'll say to them, I think you should be this, or this. And they'll leave the office going, well, he said that, but I'm not going to actually do that. So that's why the statistics are really high on why patients don't get prescriptions filled. So also as a certified healthcare or health coach, I think I would start with, so I hear that you don't want to take these medications because they want to, so tell me about that. Go into those treatments, dig deep into that. What are the reasons behind not wanting to? Essentially,
Great. So just to summarize, and I think we would all agree with that, the importance of shared decision making, and that if we're highly prescriptive in this scenario, the patient's going to do what she wants anyways, is what this pharmacist is seeing in the community. And of course, we see that as well. I'll take another comment. Please, please introduce yourself. Thank you. Thank you.
One comment would be knowing what her baseline diet is at this point. So there is some evidence that empagliflozin and carbohydrate restriction could increase risk of diabetic ketoacidosis. So that's just one thing I would say. Given the increased use of carbohydrate restriction, I think we need to be mindful of the drug interaction with baseline diet. The other would be with a 15% weight loss. Based on the direct trial, which is the counterweight program, there is massive diabetes remission. So is it perhaps that her fat mass is now dropped below a particular threshold in which her metabolism is improved? So she's had early, if we catch her early enough, where she still has preservation of beta cell function, it is a possibility that she keeps her weight at this level. You can peel back drugs without causing dyslipidemia.
Okay, so I'm going to summarize two comments. One was about the risk of diabetic ketoacidosis, the potential risk of diabetic ketoacidosis when empagliflozin is used in combination with a low carbohydrate diet. The second point is this patient now no longer has diabetes in remission? And I actually would appreciate if either Dr. Ransom or Dr. Harris address that idea of how do you define diabetes remission, and what do you do in those cases where we're now no longer treating diabetes, or are you? Tell me about diabetes remission and how you define it. Do you think it exists, and how does that impact your management?
I know, so that this is up for debate, but if you can take away all the medications and you do your A1C and measure of the a glycemic measure being fasting or anything, but if they do not meet the criteria for diabetes, I am comfortable saying you no longer have diabetes. And say, so if you're applying for insurance on this date, I will say you do not have diabetes. Some people say once a diabetic, always a diabetic. I don't prescribe to that point of view. So it's very possible. She's had 15% weight loss on top of I think a previous 5. So we're pushing 20% weight loss, which is probably over 50% of her extra weight, if you will. And so she may very well not have diabetes, but 3 medications, I'd be surprised. But the question is, if you could take someone off all their medications and they no longer meet the diagnostic criteria of diabetes at a given time, I would be comfortable writing their insurance company saying they do not have diabetes.
Dr. Harris?
Yeah, my answer for definition is identical, so no different than Tom. But my only interesting thing I've noticed in the bariatric population is insurance companies actually operate under that principle, once and always a diabetic. And so years later, when the person has an A1C of 5.8% off medications, if they use liraglutide, for example, for weight management, the insurance company doesn't bat an eye about it. They don't send me a letter that says, why isn't this person on metformin already? Why haven't they tried sulfonylurea yet? Why aren't they on basal insulin?
Right.
They approve the drug. So the interesting observation I made is that once they click that button on the file in whatever third-party insurance provider they have, it seems like the coverage for diabetes medications is long-term. And so, that's an interesting observation I made.
I do have to say, in this patient, even if the scenario was slightly different and she was now able to discontinue metformin and even empagliflozin and maintain a normal hemoglobin A1C, maybe even send her for a 2-hour OGTT test, I would not stop liraglutide in this patient. She would be at high risk for weight regain. And even if we were able to stop liraglutide short term, maintain her weight short term, and show that she no longer has diabetes at this low weight that she's maintaining, the liraglutide is helping her maintain that weight loss. So I would always continue that for weight management separate from her diabetes management. I am going to move on. I know we had lots of comments on that case. Well, we will have time at the end. Our next patient, right, Veronica. Veronica is 40. She is a teacher. She has been gaining weight over the last 2 years, and right now her BMI is 51. Asking her a little bit around what she thinks the reasons for that weight gain is. Well, she has PCOS, and she's been struggling with infertility. She actually went to our fertility clinic, went through all the first steps, got to the point where IVF was being considered. But at the fertility clinic, they told her that she would need to lose a lot of weight in order to undergo IVF. And so that really triggered emotional eating. And she does report that in the past when she's tried to lose weight, she really struggles with hunger. She has real trouble reducing her caloric intake. So that BMI target that came from the IVF clinic was 35. So this would be a 31% weight loss that they are requesting that this patient have before she can undergo IVF. So first of all, I wanted to talk to you about using our weight loss medications in women of childbearing potential in general. Our current, these drugs are not to be used in pregnancy and breastfeeding. What do you do? How are you counseling patients who could potentially get pregnant?
I can give you the my medical legal answer to that question, and I'll give you the what happens in reality answer. I think that due to teratogenicity or unknown studies in the gestational and breastfeeding fields, it hasn't been tested. Ultimately, if the person is using those therapies to improve fertility, they should at least be counseled, if not provided with appropriate contraception at the same time they're using the medication. In reality, the person is 40 years old. She has polycystic ovarian syndrome. Who knows when the last time she was regularly ovulating? She wants to get pregnant yesterday, not in 3 months, not in 6 months when I lift off the oral contraceptive or alternate therapy. So in reality, these patients often come back at 3 to 6 months down the road, not on appropriate oral contraception, and they stop the medication 2 weeks after they know they've achieved gestation. And then at that point, the counseling takes place around the risks that could or could not have happened in that situation. Yeah.
Dr. Gagnon?
Is she on metformin?
Pardon?
Is she on metformin?
Yes.
Nah.
I actually don't remember in this case. You would start metformin if she wasn't? Yeah.
And was she screened for eating disorders?
Sure.
Okay. And well, in her case, when you want to have a kid and you're 40, the clock is there. What about fast tracking her for bariatric surgery, and not long after she can actually lose that amount of weight and have the pregnancy later on?
Go ahead.
So, in terms of, bariatric surgery, it's my understanding the recommendation is at least 1 year post-operatively.
I know. I mean, fast tracking the bariatric surgery.
Fast
and then
tracking,
you wait.
go down to Mexico in a week. And, best case scenario, go, gets it in a week. And then she's 41. I mean, I don't know what the issues, if it's her or husband or what, IVF, but, but it, for her, but it would say this would, I don't, not just medically, legally, I think in terms of my understanding, I would say you would have to wait for a year after your surgery before getting pregnant.
So I would agree with you, but do you think it's that time that's important or that weight is stable?
I get, this is in reality, stable-ish. If it's starting to plateau, if the curve's coming down and there might be a bit more weight loss, maybe we'll see. If it's still on rapid decline a year later, which would be kind of unlikely at a year's time, so I don't think I've seen anyone that's still on a rapid enough weight loss at 1 year where I would be concerned.
My comments are, my level of comfort improves when weight has been stable for 2 to 3 months after trough, post-bariatric surgery. So that can, on average, happen between 6 to 9 months when someone achieves their trough weight and is stable. So I always say 2 to 3 months, and that plays into exactly what Tom was saying about the trajectory of weight loss. Initially, in the first 2 to 6 months, it's very logarithmic, but we often hear from patients in that 4 to 8 month period where they have a step down. They go, yeah, my weight was stable for 3 weeks, and then 1 week I lost, and then it was stable for 3 weeks, and then 1 week I lost, and that's why that 2 to 3 months to rule out they're still not doing a stepwise weight trajectory at that point is so important. I'll cut back for a second in this case. Medication therapy is actually not first on my mind in this case at all. The two biggest weight loss tools, and maybe Dr. Shao is about to say it here, the two biggest weight loss tools for this 40-year-old dealing with infertility are bariatric surgery and full meal replacement programs. Those are going to give you the absolute body weight reduction to get to that 31% weight loss threshold as quick as possible for this person's fertility. So in this case, actually, because I'm in an OptiFast center in Canada, full meal replacement with OptiFast would be offered at this point for this person as being whether or not you consider that meal or pharmacotherapy is a debate in itself, but ultimately full meal replacement is what we often offer this person. My concern with bariatric surgery is realistically, in the current Canadian climate, even if I fast-track this person to orientation, got her in 2 to 4 weeks, and if the team had signed off realistically in 3 to 4 months after that, she's looking at about 42 to 43 years old before she can safely attempt conception. And ultimately, this is even lower probability of carrying out a successful gestation, and that's the big concern here.
Thank you. Dr. Xiao?
Actually, I had a different comment, but the perspective from the fertility clinic is they don't want people to be at an acute weight loss stage when they want to do the harvesting of the eggs and going through that. They want some weight stability because there's some evidence out there that at the acute weight loss, the eggs just aren't as good quality or they're not as numbered. So we do try to bring down the weight, have a period of time, 2 to 3 months, and we don't know, of weight stability before we start going through the IVF process, just to let you know.
Yeah, thanks so much.
How do you define weight stability?
Well, I guess it boils down to where they can maintain, right? Is that their best weight, et cetera? It's towards an end of a program, typically there is some weight stability in that their weight loss isn't as much, or it's just been consistent for a period of time. The number stays the same. It's what we can measure.
Can I ask, so with your full meal replacement, you would run this for 12 weeks on this patient, or would you keep going until she hits her BMI target? Dr. Harris, you have to answer this one.
So I have run it up to as many as 14 and 15 weeks of full meal replacement. In this exact case, I've had patients exactly like this. And so I have pushed the envelope, so to speak, a little bit. But once again, it depends on weight loss trajectory. Ultimately, full meal replacement in something like 2/3 of people somewhat plateaus at about 10 to 11 weeks in. And it's that magic 12 where usually greater than 80% of people have developed some stability in their weight at that point. But if the weight loss trajectory is still, that person comes in at 11 weeks and 12 weeks and they've lost 5 to 10 pounds in between weeks, then I'm going to push the envelope in that case. So it depends on trajectory and response. Yeah.
Okay. Dr. Karate has a comment.
I just want to ask, as far as the BMI target of 35 from the fertility clinic, so does the panel believe that that's weight bias? Do they believe it's evidence-based? Are we discriminating against this lady based on accessing medical treatment based on her weight? Would be my first comment.
Can I answer that one? So I'm gonna ask that because I think it's a great point. So the question from Dr. Crotty is, what do we think about this BMI target that's been given to us by the fertility clinic? Is there some weight bias perhaps in giving us this target and not actually understanding how difficult it is to achieve? Are they looking at the risk and benefits to this patient, or they're just really busy and they need a way to offload some of their caseload? What do you guys think about this one?
Well, we get the same from the orthopedic surgeons. And we know the orthopedic surgeons have reason for it. The IVF, I don't know. But yeah. Most likely your natural infertility with being overweight with the estrogens in the cells. So it must help the fertility with a weight loss for sure. That must be the reason, I would assume, not to be less busy. Yeah.
I don't have the numbers, but it's, the 35% is pretty consistent, probably pretty consistent across the country.
The BMI target of 35,
BMI
you mean?
35 for in vitro fertilization. And I think it's consistent because there is evidence. I don't know about the evidence of successful conception, but in terms of, complications of pregnancy do go up with increasing BMI. I also do the pregnancy and diabetes clinic, and so see, the women through the spectrum, and usually because it's a diabetes clinic, the higher spectrum of BMIs, and we do, from preeclampsia to early delivery for different reasons, preterm, there's just increased risk. And I think the 35, I cannot quote the numbers, is evidence-based.
Well, I am going to interject, and it's unfortunate that Dr. Sharma walked out of the room because I know that he was on a paper a couple of years ago where, again, they looked at BMI versus EOS, obesity staging system, in terms of outcomes at a fertility clinic. And the bottom line of that study was that probably it was more appropriate to look at EOS, and that the fertility outcomes were more closely associated with that than with absolute BMI, although there are some technical considerations. I know certainly in this case, I did talk to the fertility specialist and write some letters around, I think I actually appended that paper, maybe that was bit too much, but to there, because I do think that, as we would do for bariatric surgery, there are these absolute BMI targets, but we also have to look at the weight change in these patients and take that into account when we're thinking about what the right timing is and what the right weight is, and looking at that risk-benefit analysis of proceeding to surgery or other medical interventions.
Just
go ahead.
Question about using the Optifast. Your patient, you're going to stop the Optifast when she gets her in vitro, or you're going to, so she's going to obviously regain the weight, and so for the pregnancy, it might not be optimal.
Oh, it's a great argument for the long-term care of obesity. Of course, we're using it as a tool to achieve another goal in this case, and forgetting about the holistic lifestyle approach that we all preach. I mean, So ultimately, in that case, you congratulate her on achieving gestation, but then strongly advise her to come right back in postpartum weeks, months 1 to 2, and become re-engaged with weight management again as soon as possible. So that's how I would answer that. I think, my overwhelming sort of feeling is that this might be a form of weight bias. That's how I feel. That's how this case makes me feel. And I don't know if that's evidence-based, but I think that, I'm no radiologist, but I think that sonographic egg harvesting becomes less effective at higher BMI thresholds. And so there's maybe some ultrasound evidence around that it's harder to cannulate the ovary when you've got more adiposity surrounding that area. So maybe that's how a gynecologist or a sonographer might argue that this as well, that the harvest of viable oocytes is suspect here. But my gut feeling is I feel like this is weight bias, and that I mean, I can probably rant for half an hour about the orthopedic story, but just to say, in the last couple of years, this was challenged at the orthopedic level of do total joint arthroplasties actually break down in people with higher BMI thresholds? And there was an article, I believe, about 2-3 years ago in Canadian Medical Journal that actually dispelled that to a degree, that arthroplasties were not breaking down at a higher rate in higher BMI thresholds, that it was a form of weight bias. Yet, despite that hitting every MD nationally in Canada, I still see it happening fluently throughout BC and all Eastern Ontario as well.
Yeah, I guess for me, every time I see a hard BMI target that's not taking into account change in weight or that broader risk-benefit analysis in terms of an individual patient, then we're looking at weight bias. I do want to tell you how this case ends, and then I'm going to open it up for questions. I'm going to hold your question, I'm sorry. This patient was actually managed really by a team approach with the doctors in our practice. So what we did is initially manage her with liraglutide. It was before NB was available on the market. Liraglutide and just regular food at first. She had an excellent response with liraglutide. And once she started to slow down in her speed of weight loss, it would have been 2 or 3 months in, we introduced first a partial meal replacement strategy to bring her calories down further. And then at about 6 months after she started with us, we actually switched her to full meal replacement, which she did for 12 weeks, hit that BMI target of 35. And we were, of course, in very close communication with her fertility specialist and got her in for her procedures really right as soon as she hit that target. Hey, you guys are going to get off. You don't have to do the last case, which I know you didn't like anyways. So we'll leave that one. I will take questions and we'll go here. Please introduce yourself. Tell me where you're from and what you do.
Sure. Jim Ellesmere. I'm a surgeon in Halifax. I've really enjoyed this session. I haven't sat through any medical sessions despite being a bariatric surgeon for over a decade now. And just the whole discussion was fantastic. And amazing how the field has developed, really. And you guys are true thought leaders, and I just appreciate your objectivity when you approach all these problems. The one question that came up was the issue of the hard cutoffs with the BMI and the weight bias, and it's a subject that's kind of near and dear to my heart, so I figured I'd provide a little bit more insight. The orthopedic one is actually where some of the best data has come out. And you brought up the issue of durability of the joints. It's nothing about durability of the joints. So just that's not where it comes from. It's perioperative risk is where it comes from. And for the longest time there was no good data on the perioperative risk. In fact, if you talk to most orthopedic surgeons, they say there's no higher risk with higher BMI as far as outcomes. In fact, if you look at the National Arthroplasty database that's been maintained, every joint that goes in Canada goes into a database. This may shock. This is weight bias. They don't record the BMI. They record all their diabetes medications. They don't record their BMI on the national. So there was actually there was no data as far as understanding. So where did this come from? And it's really just come out in the last 3 years, and that was that it was block funding in the States. And that was introduced with Obamacare, the idea that you're going to look after these 100 people with the joints, and we're going to give you fixed funding for that. And the orthopedic surgeons would take anyone, any BMI, doesn't matter. Well, what happened was it was the hospitals. They say, we're not taking anyone with a BMI over 35. Why? Because their perioperative complication rate was through the roof. They're having infection rates of like 45%. But it was completely underappreciated. It wasn't discovered by the orthopedic surgeons. We all know how great researchers orthopedic surgeons are. It wasn't discovered by the orthopedic surgeons. It was discovered by the hospitals. And it was basically in economics. They were losing money on all these encounters. It's a complicated situation, risk-benefit. There's no question. If you can't walk and your BMI is 50, getting a joint is actually not a bad thing. It's just that the risk is really, really high, and it's in economics. And so what happens so that's where the weight bias came from, the hospital saying we just can't afford to do it because these people are sitting in beds for up to a year after a joint infection, basically. So that's where that's come from. And we're seeing that in a lot of other reconstructive surgery as well. In my own practice, I do a lot of foregut surgery, hiatal hernia repairs, and the number that's well established in the literature now is about 35. The perioperative risks and the long-term disability in that case just start going through the roof. And so you look at other management strategies and that sort of stuff. But I don't understand. Like I don't really know what the IVF issue. I thought the ultrasound sounded reasonable, but I'm sure that there would be patient-specific issues. BMI is a blunt instrument. We all know that.
Yes.
But it's very pragmatic as well, as far as as far as patient management as well. So.
So I would agree. I do agree with you, and I think part of it though comes up counseling about how that counseling on how to reduce risk comes often out of our surgery clinics. And again, lose this much weight, and then I'll do surgery. It's held like a bit of a carrot. And not offering patients support for their weight loss. And then again, we do this with our bariatric surgery patients, is when we're having a discussion with a patient, there's an understanding of their overall weight loss trajectory and where they've come from. And while my bariatric surgeons may not want to operate on someone with a BMI over 50 if they can help avoid it, when we've taken that patient from a BMI of 80 and now have them at a BMI of 58, that's probably acceptable at that point in time.
Well, as far as the bariatric part, I agree, that's definitely softer. That you don't see the curves where the infection rates go off the rate. So yeah, BMI cutoffs are a really soft call, but not so much with the orthopedics. Is the numbers are pretty clear now. Basically.
Thanks so much for your comment. Any other questions? There were some. Oh, there, Dr. Crotty.
So that lady, she got her IVF and she stopped her liraglutide.
Right, so 5 half-lives, the medication is out of the system, so we stopped a couple of weeks before she had her procedure, which I thought was actually a little generous. I would have said 7 days. And yeah, she has a healthy 18-month-old now.
So I suppose my number one question was, with these hard BMI cutoffs, if we get patients down with heroic measures to these cutoffs and then we stop, we essentially take away treatment, while obviously fertility is a very specific case. You're almost throwing them to the wolves. During the pregnancy, number one, did she gain huge amounts of weight? And my second point is it more dangerous, and I don't know this, is it more dangerous to start a pregnancy at a higher BMI or to gain significant amount of weight during the pregnancy?
These are all really good questions. I actually spent quite a bit of time in sessions today and at posters sort of exploring this. I would say that we really don't know the answers to that question, but I agree the question is probably she's going to have more weight gain in pregnancy. Certainly this patient was counseled around that. And certainly she even really struggled in the couple of weeks before she had her procedure to maintain her weight loss. So there's some counseling at least around that. Most of my patients who have come off of their weight loss medications for pregnancy and breastfeeding have gained some weight. For the most part, it is a time where people are extremely vigilant. And when they know that if they do, if they're holding their weight right now, it may sort of be, as you brought up, the best weight point below their best weight, but they're now going to add back in that tool that they had that was very successful for them. They are very successful, to be honest, over the long term. But I do think that that's a really good question in terms of risks during pregnancy. Is the amount of gestational weight gain more or less important than the highest weight that they achieve in pregnancy, or do they both impact risks for perinatal complications and risk to the baby and so forth?
This came up at one of the sessions the other day, and without evidence, the consensus or the feeling was that rapid weight gain during pregnancy, indicative of excess caloric intake during the pregnancy, was speculated, I'm using almost sound like a lawyer, but speculated to be more detrimental than being at a higher weight at the start and getting up and going up there. That was sort of the consensus.
Thank you.
Just to follow on, I'd be quite similar. I get quite animated talking to women who are seeking fertility treatment and being denied based on their weight. And I talk to them, and I think when somebody is going into something knowing the facts, knowing the information, knowing what could happen, and they give informed consent, and they say, it's not for me to say to that woman whether or not her value is having a baby, whether that's right or wrong. It's to kind of, if that's her decision, that's where she wants to get, and she knows the risks involved, she wants to do that, then I see it as my role to help her, as long as we can do it in the safest way possible. But I don't think, so again, I'd be very similar. I would consider medication, as long as she knows contraceptive while she's on it, and try and get her weight stable. But I think it's a bit kind of unfair to kind of hold that back if somebody's going in with their eyes open.
Yeah, thank you. So Dr. Crotty just saying that to give the patient some agency in assessing where the risk-benefit balance lies for them, and not being so prescriptive about it from a physician perspective. Any other questions or comments? Awesome, it's Friday afternoon. Thanks so much for sticking it out with me. And thank you so much to our panel. I actually, most of these cases were mine, and you've really given me some food for thought. I honestly, looking back, may have managed these patients different, and I'm actually looking forward to getting back into the clinic next week and tackling things with a bit of some different perspectives to look at things from. So thank you very much.